Welcome everybody to this Mental Health and COVID-19, the Need of the Hour Expert Profile meeting launched by OmniCuris. I'm Dr. Marcelo Setkovich from Buenos Aires, Argentina. And this pandemic challenged all we knew about human health. And one of the facts that emerged fastly was the compromise of mental health issues, not only in people affected by the COVID, but in the general population, driven by fearing, locking, and losses. For this reason is that today we have two experts that will enlighten us about how to handle and how to recognize these mental health issues during the COVID pandemic. With us is Dr. Hisham Rami. Dr. Hisham Rami is a renowned professor at the Institute of Psychiatry at the Ain Shams University in Cairo, and he's skilled and expertise in psychiatry. The main focus of interest of Dr. Hisham are stigma on mental health, e-mental health, and child mental health. Our second speaker will be Dr. Grigory Usov. He's a MD, PhD professor. He's the head of the Department of Psychiatry and Medical Psychology of the Omsk State Medical University in Siberia. He's graduated at Omsk State Medical Academy, and his scientific interests lie in the field of diagnosis and treatment of psychotic and mood disorders, and also anxiety disorders. Most interestingly, in 2020, Dr. Usov designed a complete 2 studies of efficacy of the short-term remote internet-delivered psychological and psychopharmacological interventions for patients with stress-induced mixed anxiety and depressive disorders, a subject that is absolutely related with the facts of this pandemic. After this, I will ask Dr. Hisham Rami to start his presentation, and then we will ask him some questions, and then we will start the round questions with Dr. Grigory Usov. Dr. Rami.
Thank you, Dr. Marcelo, for your very generous introduction, and welcome everybody to this important webinar meeting. I think this is a timely meeting because you are facing so many challenges. It's a very hard time we are facing in the field of mental health nowadays. I would also like to thank the Indian Medical Association for hosting this event. I'll give you just a very few slides regarding mental health and the corona epidemic. What are our challenges and what are the opportunities? My name is Hisham Rami, as have been introduced by Dr. Marcel. To start with, this is a very hard time for everybody in the world. There is a virus that seems to be killing people, and we don't know a lot about. Our life has changed. Many countries have been under lockdown. Many people have been isolated. We have been advised to have social distancing. So it is a very, very stressful time for everybody. What we know now that the relationship between mental health and the coronavirus or the COVID epidemic is a bi-directional relationship. Actually, it seems that coronavirus increases the rates of mental health problems and challenges the resilience of the population from a mental health perspective. And at the same time, it seems that our mental health well-being, if it is affected, it seems to increase our susceptibility to be affected by the COVID virus or the coronavirus. I will quickly review some findings. The impact of the corona epidemic on mental health. In general, every 6th adult in the world seems to suffer from mental health problems. That's before the epidemic, and that mental health is a very important economical as well as a medical issue. What we found that in all over the world, the rate of mental health problems are on the rise. If you look carefully at this slide, comparing the rates of some common emotional problems, 2019 and then in 2020 after the corona epidemic, we can find that the rates are really increasing. Symptoms of anxiety disorder have almost tripled or quadrupled. Symptoms of depression have almost quadrupled, and symptoms of anxiety disorders have also increased a lot. For instance, if we reviewed mental health problems in Belgium, they have increased enormously. In Egypt, depression, insomnia, and anxiety have almost reached severe rates. Also, the mental health service have been affected in our countries and all over the world. For instance, in Egypt, the use of outpatient and inpatient mental health services have been decreased a lot. Demand for face-to-face mental health services have really decreased. And this raises the question is, are people not suffering, or the access is denied now because of the lockdown and all the changes and the fears? There is now in Egypt, and I think all over the world, increased focus on digital self-help and digital mental health services. Of course, there is still many limitations for these solutions. The illiteracy regarding digital technology, not everybody, at least in our region of the world, have internet access. Not everybody is accustomed to using this as a way of seeking help. What the coronavirus is doing and how we are living it is affecting our stress system, the hypothalamic pituitary adrenal axis, the noradrenergic system, and the immunological system as well. We know that when you are stressed and living in very stressful times like the ones we are living in, many areas of the brain and many connections to other areas in the body are affected. And these are just examples of how stress can really lead to disturbance in all the hormones and the neurotransmitters in our brain and in our body. We know that any inflammation can lead to depression. And corona, of course, is an inflammatory disorder at the end. This is why the rates of emotional disorders are on the rise. In addition, we know that when you are emotionally stressed, the hypothalamic pituitary adrenal axis is hyperactivated, leading to excess cortisol, which will affect not only metabolic parameters in the body, but also your immune system, and you might not be able to fight the virus or the disease resulting from the virus. We know also that depression is now considered a systemic disorder, and that rates of depression that are increasing either post-corona or actually due to the life changes because of the epidemic are affecting other systems in the body, increased rates in cardiovascular disorders, particularly ischemic heart disease, through affecting many blood clotting mechanisms. We know that when you are stressed, your immune system does not function well. This is just a slide to show you that when you are stressed, through the connections of the hypothalamus and the amygdala, it really affects your natural immunity and your humoral immunity as well. And this is another very illustrative slide that I'm going to go through. So why isn't everybody getting ill? This is because not everybody will be affected by stress at the same time or even by the corona. There has to be some vulnerability for an individual to develop a real, genuine psychological disorder. So the problem is we now know that we are facing many challenges. Mental health services are not used as much as people with pre-existing mental health problems are suffering from excessive relapses and excessive exacerbations. People who have not been ill before are becoming ill now, and the access to service is not very smooth as before. So what can we do? First, we have to increase what we call our psychological immunity, so that we are not stressed or we can cope with stress, or what is known as stress management. This would include having an active lifestyle, structuring your daily activities, sleeping well, becoming hydrated. These all are general advice that will keep us more resilient to the effect of stress. Also, this is a very important issue. The WHO have advised social distancing. While we know that being isolated will increase your psychological vulnerability and stress. So what we are advising in Cairo and in our region is physical distancing while increasing socialization. So you can talk to people, you can connect them through the internet, whatever you do. Spirituality seems to play an important role in our psychological resilience and stress management. And of course, if you can do some relaxation techniques, this will be really helpful. What we are focusing now in Egypt, and you're doing a study about it, is whether social interaction, even online or digital social interaction, would really impact our oxytocin release in our brain and body, and this will give us more resilience to the effect of stress and might in decreasing the impact of the COVID and the life changes on our body. And at the end, do not forget, all psychological problems and psychiatric disorders need early detection. The earlier we detect the illness, the earlier we can intervene and the better outcomes we will have. So we are advising early detection and management of any emotional problem or psychiatric disorder. And then, of course, we can use psychosocial therapy, internet delivered or online or whatever mode we can do this. And of course, we have still our psychopharmacology.
Thank you very much, Dr. Isham Rami, for this wonderful resume of how we can deal with stress and the COVID. I have some questions for you in relation with this. Can you elaborate more on the notion that the relationship between COVID-19 and mental health is bidirectional?
Yes, the notion is that the coronavirus actually lead to mental health problems. People who have survived the infection, and I think Dr. Uzuf will explain it more than me, are suffering from higher rates of anxieties, depression, fatigue, and stress symptoms. So it seems that the coronavirus is impacting our mental health. In addition, the life changes that have occurred during those years are also stressful to our mental health. At the same time, if you look at the problem from the other direction, suffering from mental health problems actually impair your judgment and might lead you to become more vulnerable to interactions and even getting infected. In addition, as I have shown in my brief presentation, mental health problems, particularly emotional problems like depression and anxiety, seem to be decreasing the immunity of individuals, making them more vulnerable to catching the virus. And if they catch the virus, they are going to suffer from a more severe form of the disease. So it's a bidirectional. Corona is impairing the mental health, and mental health is making people more vulnerable to being infected and suffering from the disease. This is what we call bidirectional relationship.
So that's great. That's very clear. And in your opinion, what is the impact of COVID-19 on people with pre-existing mental health problems?
A big problem, I think, all over the world and in our region as well. The coronavirus and the epidemic and the measures taken by the government have led to the following. People with pre-existing mental health problems now are suffering and are not able to reach mental health services with ease as before. For instance, we have a very large mental health service called Abbasiyya, which is a historic mental health hospital in the Middle East. Before Corona, the rates of admission was higher. The rate of using the service was much higher. People were coming even not to be assessed, even to get their medication. We have found that almost 25% decrease in people getting their medication, which led to a problem of increase in the relapse and exacerbation. So people with pre-existing mental health problems are really suffering during the epidemic. They are getting the diseases more severe, symptoms are exacerbating, their access to service is now very limited. We have tried to establish a digital mental health service through the internet, what we called in Egypt telepsychiatry. But unfortunately, many of our patients with severe mental illnesses were not able to use this service. So this is a very hard time for people with pre-existing mental health conditions, and governments have to do something about it.
Doctor, from the blue, I know you are interested in child psychiatry, and you probably know that a few days ago, a paper was published in JAMA Psychiatry about the concern with suicidal behavior in child and adolescents in the United States. What is your experience? Do you have any data about that?
Yes, I have some data about our country and our region. It seems that after the major changes that happened in the living situation after the corona epidemic, it seems that isolation have increased. People are not getting in touch with each other. In our country and our region, schools were closed, universities were closed, and everything was done online. It seems that adolescents and children have been spending lots of time on the internet, either gaming or either doing whatever they are doing. For some reason, it has been shown that people, adolescents and children, are getting more distressed. Their, acting out is increasing. Their suicidal ideation seems to be on the rise. And the support system which has been done, or the access to early intervention services, have been really denied because of the things that is happening. We hope that this year schools and universities are going to be open for direct interactions and face-to-face, and this will help to manage such problems. But it's a very good observation, actually.
That's great. I have another question for later. And another question, social distancing versus physical distancing and the impact of mental health.
This was a big problem in Egypt and the Middle East region. People followed the advice literally. So they stopped communicating with each other. Elderly people who are already isolating some visits from their families have been denied those visits because people thought that social distancing means no contact or no communication with others. What we are advocating now is a different term, which is physical distancing with socialization. We are trying to advise people that talk on the phone, talk as much as you can. Try to communicate using whatever medium is available. It seems that the more socialization, the better the mental health of everybody, including the elderly, including the children, including the adolescents, including even people with pre-existing mental health conditions. Socialization is a very important protective factor against mental health problems. Having a good social network seems to be really protective. So what can we do in those difficult times? That we are trying to teach people, having like what we are doing now, something like a Zoom meeting where they can see each other, talk a lot, discuss their problems, even tell jokes to each other. This will improve their emotional well-being and it will impact on their mental health. So we would like to differentiate between physical and social distancing.
Okay. And this is very important question. Which are the challenges facing delivery of mental health services during this difficult time?
We are facing enormous challenges in delivering mental health services. I'll tell you a problem that we faced, and maybe we can share our experience. If a schizophrenic patient develops COVID, where are they going to be treated? General hospitals in Egypt and the Middle East refuse to take them. We do not take people with mental illness. We do not treat people, I'll tell you what exactly they say, crazy people with sane people in the same ICU. So what we did, and which I did not agree with because it increased the stigma, we had certain ICUs and hospitals dedicated for mental patients who develop corona. We reintroduced the idea of segregating mental illness people with mental illness from the normal population with COVID, which is not the right thing. But actually, this is a very difficult situation. People with mental health illnesses are afraid to seek help now. They don't want to go to clinics. They don't want to go to services because we advise them, do not interact, do not have social contact, do not do blah, blah, blah. People with pre-existing conditions are now having difficulty to access already existing services for their medication and for their support because we are now either on a lockdown or decreasing the amount of slots for them. And when they get corona, they are having a difficult time getting medical treatment for the corona. So it's a very challenging period for people with mental health problems, getting good quality service for them.
It's like a second hit stigmatizing procedure.
Again, yes, sir. Yeah. And it's a very sad situation.
Yes. And the final question, Dr. Grami, the impact of COVID-19 on mental health and healthcare personnel and how to ameliorate the impact. This is a very, very important question.
In our region, and I think all over the world, we had what is known as isolation hospitals. Hospitals where there are many strict measures in order to isolate people with coronavirus. People delivering this service were always wearing masks, gowns, and stuff like this, and risking their life and trying to take care of the people with COVID, particularly at the start of the epidemic, where everything was vague and everything was considered a disaster. Those people were really stressed, were really anxious. And I'll tell you another problem regarding stigma. When they finished their shift, they would like to go home. People were afraid to talk to them because they are coming back from hospitals in which there is a coronavirus. Some people even decided to kick them out of their buildings because they think they are carrying the virus back from the hospital. So, of course, they needed support. The Egyptian government actually delivered telepsychiatry support system for those people. And at the end, we started sending them social workers and psychologists and even young doctors inside the isolation hospitals to talk not to the patients, but to the healthcare workers delivering the service. They are challenged, they are stressed, they need as much support as they can get. So this is another mental health problem due to the coronavirus.
So you also had this situation that the mental health workers were avoided in their own houses, for example.
Yes.
Yes.
A very sad situation. Huh? Some of them were kicked out of their houses because they are coming from hospitals where there is coronavirus. Yeah.
Okay, Jean, thank you very much for your talk and for your answers. And then we are moving to Dr. Gregory Usov, and we start with him with a chunk of questions we are developed for him. First question, Dr. Gregory, what mental disorders are associated with COVID-19 and why?
Thank you, Dr. Marcelo, for the introduction. Thanks, Dr. Isham, for your detailed analysis of interaction between coronavirus and mental health. And I am starting the first part of my report. Okay, what mental disorders are associated with COVID-19? Throughout history, humankind faced epidemics, and all epidemics associated with mental disorders. New coronavirus COVID-19 pandemic is not exception from this rule. This is a well-known scheme of impact of the coronavirus infection, COVID-19 pandemic on human health. It's very interesting. This picture was published not in the scientific journal. It was published in Twitter of the doctor. And the doctor indicated four basic waves of impact on human health associated with COVID-19 pandemic. The first wave is means immediate mortality and morbidity of COVID-19. This is a direct consequences of pandemic. The second wave is impact on patients with acute somatic states, somatic conditions, not related with COVID-19. The next wave is impact on chronic somatic patients. And the fourth, the last wave, maybe its wave is so problematic for public health services, is mental disorders, is social and mental trauma, economic consequences, problems of burnout, and other. From the first week of lockdown of pandemic restrictions, we get a lot of information about increasing incidence of mental disorders in different countries. In Europe, North and South America, Southwestern Asia, and Middle East, and any other regions of the world. The most common conditions in COVID-19 pandemic are depression, anxiety, and sleep disorders. Of course, a lot of these cases, clinical cases, didn't get diagnostical threshold. These were sub-threshold conditions, but these subclinical, subsyndromal disorders, the numerous of these disorders very realistic reflect range of the problem of mental disorders in COVID-19. Another mental health problem associated with COVID-19 is cognitive impairment. Controversy, the depression, anxiety, and sleep disorders, cognitive problems arise weeks and months ago after infection. Cognitive disorders impact about 80% of patients with COVID-19. The most typical clinical features of this deficit are problems with work memory, decreased ability to self-service, attention deficit, slow thinking, and any other say. Neurocognitive profile of this deficit is the same to traumatic brain injury. There are no strong correlation between level of cognitive impairment and severity of respiratory failure. Many patients after COVID-19 have long-term mental disorders. After recovery, these patients have long-term depression, long-term anxiety, about 15% of recovered patients. About 30% PTSD, post-traumatic stress disorders, memories, traumatic memories about respiratory insufficient, about suffocation is most common symptoms for recovered patients. There are very interesting scientific data about high prevalence of long-term mental disorders after COVID-19, more frequently than after SARS-1 and MERS, Middle East respiratory syndrome, and also coronavirus infection. That's all in my first question.
Yes, this is just go with the second question. Why are mental disorders so frequent in COVID-19, Dr. Usop?
The first my questions was what and how many, and the second question is why. Why are mental disorders so frequent in COVID-19? I said in the first part of my report that depression, anxiety, sleep disorders, and cognitive problems are very frequent mental disorders in COVID-19. During the pandemic, prevalence of these disorders increased several times. Dr. Isham said about triple, quadruple is very, very exact numbers. In this study showed on the slide, prevalence of anxiety and depression was estimated with two objective scales, GAD-7 for diagnosis of generalized anxiety disorder, and PHQ-7 for depression. And we can see the prevalence of mental disorders increased in 4 times. As we can see, mental disorders and COVID-19 have complex origin and genesis. There are at least 2 principal paths to develop mental disorders. The first one is biological, structural, and functional injury of the brain. Coronavirus may injure brain itself and also may injure brain secondary damage due to cardiovascular disorders, respiratory disorders, inflammatory mediators, cytokines storm, etc. The second path associated with social stress, and Dr. Isham said more than enough about this side of the problem. Lockdown, loneliness and isolation, fear of infection, fear for the health of relatives, elderly relatives, economic troubles, the loss of job, and any other problems may start the mental disorders. Etiology of cognitive impairment is more different and not so obvious. There are a lot of factors take part in the development of cognitive impairment. It's also maybe systemic inflammation, problems with brain damage, damage of brain issue, coagulopathy, and also deficit of social communication may produce problem in a cognitive field of our mental health. Causes of the cognitive impairments are also associated with the COVID and their prognosis course may be different. The course of mental disorders in many patients may be long-term. Many patients recovered after COVID-19, but they have long-term mental problems. The most frequent mental problems, anxiety, depression, and PTSD.
This is the next question, and I was wondering about this situation means that we are facing in the next future with a huge burden of diseases in the mental health field associated with COVID, directly with the infection, and also for people that didn't suffer the infection. And this means that we need to be prepared. We need to be ready to deal with this. That will be really a huge burden for the mental health system.
Of course, I totally agree with you. The burden of pandemic for mental health is large, and the real range we can estimate in the future, in the next years. We can see mental health problems in patients who had COVID-19, and we have mental health in people who have never suffered from COVID. They are not contacted with virus, but they have significant mental health, and they need to medical help, medical support from mental health specialists. In our country, psychological support is very popular, and many people who had never suffered from COVID-19 ask help from the psychotherapist.
I guess. So let's proceed with the next question, Dr. Usov, about which are the key points for the smart choice of psychopharmacological drugs.
Nowadays, in different countries, published different guidelines for physicians for treatment, for diagnosis and treatment of mental disorders in COVID-19. For example, in this slide, you can see guides from India, guide from Africa region, and this guide is from Russia. Algorithm of diagnosis and therapy of mental disorders in pandemic COVID-19. In Russian, just in Russian. What are the main principles of choice psychopharmacological drugs in COVID-19? These rules are simple, and these rules are common for patients with comorbid physical and mental disorders. Mental disorders in this situation are depression, anxiety, cognitive impairment, and physical disorder is COVID-19. In the first of all, psychopharmacological drug must be effective in treatment of depression and anxiety. Treatment of depression and anxiety are common for all situations and for COVID-19 too. According to the severe disease, pharmacological drug must be safe and acceptable. Somatic physical condition of patients with COVID-19 is very difficult, very severe, and we have to use safe psychopharmacological drugs. Also, psychopharmacological drugs must be free from potential drug interaction between another psychopharmacological drugs, and especially interaction with physical somatic therapy. If you prescribe psychopharmacological drug to COVID-19 patient, it's important to take it simply, very simply. The best regime of dosage is 1 tablet or 1 caps per day. COVID patients also take a lot of meds, somatic meds, and new drugs should not to complicate therapy. This is my short report of third question.
I have another question about over this topic, Dr. Usov. You mentioned the possibility of pharmacodynamic interactions between drugs. Did you have any particular experience with some particular drug, for example, antidepressants or so on? Can you go further on this?
Thank you, Dr. Marcelo, but I want to answer your question in the next topic of my report.
Okay. Let's go to the next question about the multimodal aspect of drug interaction.
Yes. It's a very interesting question of real clinical practice, and I want to pay attention for this topic. Multimodal aspects. Why is the problem complex? Why is the problem multimodal? In cases of comorbidity of COVID-19 and mental disorders, we meet these different aspects of drug interaction. From the one hand, we must pay attention for the pharmacodynamics and pharmacokinetics. It's classical aspects of drug interaction. From the other hand, there are special issues of interaction between antidepressants, antipsychotics, and other psychopharmacological drugs with antiviral drugs. And these two questions don't look same. The first question, classical pharmacodynamics, pharmacokinetics relations between psychopharmacological and somatic drugs. General questions of interaction between psychopharmacological and somatic meds are well investigated. We know about risks of combination of SSRIs, selective serotonin reuptake inhibitors, with beta blockers, non-steroid anti-inflammatory drugs, indirect anticoagulants, and any other. Yes, SSRIs is a very safe class of antidepressants, also has negative drug interaction. Tricyclic antidepressants. Has not recommended, potentially dangerous interaction with anticholinergic drugs, cimetidine, sedative drugs, and sympathomimetic agents. All antidepressants should be carefully combined with anticonvulsants. For example, carbamazepine decrease concentration of antidepressants, but valproate controversy increase concentration of antidepressants. According to this conception, the least risk of drug interaction have blue highlighted antidepressants in alphabetic. Agomelatine, vortioxetine, not alphabetic, sertraline, citalopram, escitalopram. These 5 antidepressants. These antidepressants have minimal effect, minimal influence on cytochromes system, cytochromes P450. In the daily practice, we can check this interaction with special tools, drug interaction checker from medscape.org and the drug interaction checker from drugs.com. In my practice, I preferred the first one, medscape.org, because the second tool work only with molecules that registered in United States, only in United States. But in the Russian, we have different spectrum of psychopharmacological drugs. It's very convenient. You can use it in apps, in internet web browser, and you can get answer for your question is very rapidly. But interaction of antidepressants and antiviral drugs looks very different from the previous picture. For example, it's a very significant example, 2 antidepressants, fluoxetine and fluvoxamine. These antidepressants have a very strong potential to blocking different subtypes of cytochromes P450. But fluoxetine and fluvoxamine looks very safe for the combos with different antiviral drugs.
It's very interesting, this data on interaction with antiviral drugs for fluoxetine and fluvoxamine. And for me, it's very nice to know that 15,000 kilometers ahead, we use the same drug checker for check interactions, Dr. Usol. And there was some paper published a few days ago, a couple of weeks ago, about fluvoxamine and COVID. Do you have some? I don't know. It's good to do that, but do you have any comment on that?
Oh, it's very interesting scientific data. This this article was published in November in 2020. The first author was Lenz, and in this February was published the continue of this study. In this study, published very interesting and very optimistic data about efficacy of fluvoxamine in prophylaxis of severe complications and death, prevention of death due to coronavirus infection if you take fluvoxamine in high doses, about 300 milligrams in day. But pharmacological company laboratories with headquarters in Chicago, United States, yes, don't use this data in promotion of your antidepressant. I don't know about situation in different countries, but in Russia, fluvoxamine is an antidepressant. In our country and headquarters of Abbott laboratories strictly prohibit promotion of this data due to this preliminary character. But this data is very optimistic, is very interesting, and this effect of fluvoxamine can be explained due to this affinity to sigma-1 receptors.
Okay, this is very interesting, and it's completely out of the label indication. It's just a comment. I would like to thank you both very much for your talk, and I guess we have some time for a discussion. I have a couple of questions for you. First, it's interesting to say that in Argentina we developed a survey early in the pandemic, where at the 7th day we developed a telephone survey, and we found a big amount of anxiety and depression symptoms, and this was confirmed across the time. But it was observed that we have to avoid to confuse anxiety symptoms that sometimes means a normal response to danger and fear, and something that is to be expected with, and not always this goes to clinical depression or anxiety. What is your Dr. Gregory and Dr. Isham comment about this?
Okay, thank you, Dr. Marcella, for your question. I tried to slightly touch this problem in the first part of my report. It's a very important problem, especially important in distant communication between doctors and patient. For the solving of the problem, we can use restricted diagnostical criteria, and we can use self-checking inventories. For example, I said GAD7 and very popular in the last years PHQ for depression assessment. And in difficult cases, we have to try to see patients offline in our department and our room. Yes, this is my opinion.
Okay, Dr. Isham, something to add to this?
Thank you. Yeah, we have the same problem in Egypt as in Russia, as all over the world. Is this the normal anxiety, or this is pathological or an anxiety that fulfills the threshold of a disorder? What we did and what we taught volunteers and social workers who have been giving support to families and patients and stuff like this is use the criteria of impairment of function or improvement of function. If the anxiety has led to actually being more functioning and taking more care regarding what to do and what not to do, we said this would be normal anxiety, and this is helpful anxiety. If the anxiety has led to impairment and great suffering, we told them this might be an actual disorder. Another parameter that we used is if you talk down the patient, or if you talk down the individual, if he is easily or she is easily reassured, then this is not a disorder. This is usually a normal anxiety. We told them to teach or to help the patient do some breathing techniques or deep breathing exercises. If the success was very rapid, then probably this is normal anxiety rather than true anxiety disorder. And of course, using the scales would be very helpful as well. But it's a big problem differentiating between normal anxiety and pathological anxiety.
So you train people in relaxation and breathing techniques, and,
Yes.
and this was useful for many people. That is great, because we have to think about giving mental health care to people that is far away from our office. So this is a good way. And I have another question for you both, and it's related that you know that this pandemic carried a very special situation, that is the huge amount of people that died in solitude in the clinic, and the relatives do not have the opportunity to say goodbye to farewell his parents, his relatives, and this seems that carry the possibility of a huge amount of abnormal grief process in the people. Did you saw this? Did you have any comment about that? Yes, Gregory.
It's awful. It's absolutely awful situation. One example from my life. I am head of department from this year, and my boss, my professor, died from COVID-19 in October of last year, and we never see we never seen them, so we never saw them after last meeting, and it's awful. But for relatives, this trauma is more difficult. And we faced this problem in May and June of last year, when the mortality from COVID-19 in our country increased to the significant numbers. In my opinion, and this is opinion of my colleagues, these relatives need intensive psychological support. It's awful. It's really awful.
Really, Dr. Rami?
I totally agree. In Egypt, since the time of the pharaohs, death is a very major event, and people in funerals, we have elaborate rituals and we have elaborate things to do. During the time of the corona, all of this stopped, to the extent that some critically ill patients refused to go to hospital for fear of dying alone in the hospital without having those elaborate rituals and saying bye to their relatives and stuff like this. People were really concerned about sending their relatives because they are not going to see them and do the rituals that are naturally in Egypt being done. The other thing is, after death even, some people, and this is another problem with the stigma, refuse to bury the bodies in the normal graveyards because they were afraid this is an unknown virus is going to spread through the soil and they should be burnt or incriminated instead of burning. And this is something a taboo in Egypt. Bodies have to be buried in a box inside a certain room in the earth. So it was terrible. Where I work, which is a university clinic, we had so many people coming grieving, not only because of the death of their relative, but because of failing to say goodbye appropriately to them and failing to honor them after their death by having a funeral and somebody comes and read Quran or somebody reads from the Bible and stuff like this. So it is really a terrible situation. I totally agree with Dr. Gregory and yourself.
I think this is the saddest part of the whole pandemic, is the sad of the relatives.
May I say one short sentence? Some people don't believe in death of his relative when they see closed coffin, closed box, and it's a big problem too.
We are reaching almost the end of our meeting, but I would like to profit both of you in 1 minute each, your experience and which, from your point of view, is the most important challenge facing the new development of telemedicine in mental health. Which will be your best tips for it? Dr. Gregory?
Yes, thank you, Dr. Marcella. In the start of this meeting, you said about my publication. Me and my colleague completed the short study, open label, not placebo controlled, and any other options, open label, 1 month study, when we use distant psychological therapy without medication for patients with mixed depressive and anxiety disorders. We saw the good efficacy of this intervention, and during this study we conceptualized the weakest points of this variety of mental health service. The first challenge is technical support. Patient and doctor must have good devices with fast internet connection. The second part is a problem in the small villages and small cities. The high-speed internet is not acceptable for all people. The second challenge is absence of trust of patients in the efficacy of this method. Patients usually get help in live contact with the therapist, but internet delivered therapy is a new method. Yes, my colleagues used internet delivered psychotherapy before pandemic, but the range of this method increased significantly during the COVID-19 pandemic. And the third challenge is doctor's qualification. doctor's qualification in principle of psychological therapy, general principles, not for remote help, psychological qualification and qualification, ability to treat patient with technical devices. Thank you.
Well, that's very perfect resume. I always start my the approach. I'm not a psychotherapist, but a psychiatrist. But I almost start to the patient saying that previous to the pandemic, there was a paper published demonstrating that telepsychotherapy was equal effective as in-person telepsychotherapy. And Dr. Rami, your comment about this topic?
Totally agree with what Dr. Gregory have said. We have the same problems. We have two additional problems. Actually, sometimes the healthcare workers, the psychiatrists or the psychologists do not believe that internet-delivered psychotherapy or telepsychiatry is effective. The other unique problem is legally in Egypt, you are not allowed to do this. You have to see, particularly in prescribing medications. It is written by the law. In order to prescribe medication, you have to have assessed the patient in your office. So this are the two main barriers. Besides, of course, sometimes there is no internet, even in some small villages, not only fast internet, but no internet as well, and the need for technical support.
Okay. No matter what government says, telemedicine is here for staying.
Yes.
So, Dr. Usov, Dr. Rami, it was really a great meeting. I guess we have learned a lot from your experience, and you gave us a lot of new knowledge that will help us and all the people attending this meeting in very important information. I would like to thank you very much, and I would like to thank you, Krishna, and all the people of Omnicare for helping us and getting us to being here, and all the people attending this meeting for the staying here. And say goodbye, stay well, and take care. Thank you very much.
Thank you. Bye-bye.
Thank you.